Can I press my paper now?
Yes. Okay,
Can you
now,
see it now?
yeah, we have to wait. Okay, now we see. Now just put full
Press
screen. Full screen.
Okay.
Yes.
Okay, I'm very sorry.
And now we cannot see you. Can you? Because I think you switched off the camera. So can you please now just press full screen and then we will move further. Okay, and then can you maybe switch on the camera, because you press the stop video, I think. Otherwise, you can start presenting, that we won't lose time.
So I should press the stop share?
No, do not press that. Just the video that we can see you.
The participants, should I press
No, on the left side you have a mute and stop video.
Start video.
Yes.
I can press start video?
Yes, you can. Okay, now we are perfect. So now you can present us your work.
Okay.
So please.
No, thank you for the patience.
No problem.
I'm going to talk about the disturbances of the hepatic epigenome in hepatocellular carcinoma and the pathophysiology and the role of the monozygotic twin. How can I go forward now?
Okay, so you have the arrow. Can you see it
yes.
in the bottom, or just click on the arrow on your computer? I mean that you can move further with the slide.
Yes, I'm just trying to do that. It's not going.
Because we cannot press it for you.
Yeah. God, I'm really sorry. It's one, but it's not moving. I'm really sorry about this. I'm taking all my time.
So can you move the slide as you usually do when you're presenting? I don't know, when you're just looking on your computer. Can you move the slide or not?
No, the slide cannot move as I usually do. It's just stuck.
Okay, then maybe I suggest that you exit a full screen and you just show us the slides in the manner that you're preparing the presentation.
I'm very sorry about this. Okay, now. Yeah, it's moving now.
Yep.
Is that okay?
Okay. Yeah, now it's okay. Great. Okay. Now
right, I'm very sorry. So, hepatocellular carcinoma is the 5th most common cancer worldwide, with about 80% found in the endemic areas of hepatitis B in Africa and East Asia. The age standardized death rate is about 38 to 100 per 100,000. 70 to 90% develop on a background of cirrhosis, with a 100-fold increased risk of hepatitis B virus with HB virus, and it's mostly found in the HBV endemic areas. In the Western world, alcoholic cirrhosis and hepatitis C are the risk factors. There's 2 to 4 times increased incidence in males than in female, but there is no specific genetic abnormality yet known. But we know that in cancerous cells, more genes are affected by epigenetic than genetic changes. In cirrhosis, you could see that the HCC occurs mainly due to chronic injury and regeneration. So the dysplasia occurs at the stage of the regeneration and dysplasia. And it takes 10 years to have chronic hepatitis, 20 years to develop cirrhosis, and 30 years to develop the HCC itself. So it therefore affects patients aged between 50 to 70 years. But however, there is an earlier onset between 25 to 40 years in the HBV endemic areas with earlier exposure and aggressiveness of the cancer. This HBV can be directly oncogenic in these patients, incorporating into the host DNA and causing HCC in the absence of cirrhosis, as you see from here going this way and avoiding the cirrhotic stage. So there is also a family history of liver cancer, which increases the HCC risks independently of hepatitis. And there is a combination of a family history of liver cancer and hepatitis B or C seromarkers, which gives a 70% elevated risk and prognosis. So we think the hereditary component may be acting in concert with environmental factors, such as hepatitis B, aflatoxin, or other epigenetic factors. So as familial clusters of HCC are mostly described in areas with endemic HBV infection, there is a limited attention to the role of primary genetic and epigenetic factors in HCC. The genetic contributions, as we know, may explain the presence of healthy or non-healthy carriers of hepatitis B surface antigen, and the carrier state being commoner in males. So the aim of the study was to identify case studies on familial HCC, the primary genetic and epigenetic factors which may be involved, and the clues it may render to prevention and therapy. So it was carried out by an electronic search using the Medline database to identify original published cases on familial HCC. And 16 reported cases were found between 1965 to 2016. Kaplan and Cole in 1965 showed 3 male adult siblings, age 44 to 49, 64. Hartstrong and Baker, 1968, showed 3 male siblings, age 11, 22, and 31, with no evidence of hepatic disease. Dennison et al., 1968, showed familial hepatoma on a background of micronodular cirrhosis. Obashi et al., 1972, showed familial clustering of asymptomatic carriers. Gilmore et al. Showed 3 or 4 male siblings in a Chinese family. Lynch et al. Showed 2 familial aggregations in Thailand. Harvey et al. Showed 3 male siblings, 33, 43, 66, which suggested a pattern of involvement not occurring by chance. Chang et al. Especially showed fraternal HCC. Albert et al. 1991 showed clustering of HCC in Alaska Native families. Locke et al. 1991 again showed HBV infection in family members. Liu et al. 2014, and myself showed 2 male siblings with 24-25 in an endemic area in Cameroon. Chandra et al. 2016 showed the first reported case in India with 2 brothers having no associated risk factors at all. Those genetic factors could be involved. Now with the monozygotic twins, 3 cases have been reported. Dams in 1971 showed hepatoma in familial cholestatic cirrhosis in childhood. Demi et al. In 2002 showed simultaneous HCC in identical twin brothers, and Kadivak et al. Showed HCC in identical twins in Chile. So I believe that epigenetic studies in monozygotic twins will improve the understanding of HCC. Why? Because it will avoid the confounding influences of consecutive genetic backgrounds, age, or cohort effects. The epigenetic variation analysis in twins will identify the susceptibility loci that may be sensitive to modification by the environment. Monozygotic twins have very similar epigenetic profiles, but have surprisingly high rates of disease discordance for many other disorders like metabolic disease, autoimmune disease, and cancer. And we've also shown that the older the monozygotic twins, the greater the discordance. So which means the difference in disease occurrence between monozygotic twins may be interpreted as a result of environmental factors having their influence with time, as opposed to, although there may be some stochastic effects. So with the advent of new generation DNA sequencing, the identification of host factors such as the single nucleotide polymorphisms may relate to various biological pathways that are involved in liver carcinogenesis, which will help us elucidate the pathways in HCC. So the pathophysiology obviously occurs involves the genetic factors such as genetic mutation, chromosomal rearrangement, non-coding RNAs, mRNAs, classical Mendelian inheritance occur in rare monogenic disease, and this will give rise to genomic instability, which will avoid apoptosis, avoid tumor suppression, promote angiogenesis, promote invasion and metastasis, and sustain proliferation. There is also multifactorial inheritance seen in the novel DICR germline mutation and altered liver zonation, which contribute to HCC regardless of viral infection. There is nucleotide polymorphism, which shows different single nucleotide polymorphisms regulating the various pathways and leading to the manifestations of risk factors. There are also an overexpression of the apolipoprotein families, ApoA, A2, C3. There's also increased serum amyloid A protein seen as in proteomic profiles in HCC cancers. And there are tumor markers such as serum alpha protein, which are elevated in 50 to 60% of cases in HCC. So it could be useful as baseline, the global gene expression of the profiling of profiles revealing a small set of genes, pink K1, which is a secretory trypsin inhibitor. It's also a potential HCC marker. So as few genetic mutations are required in neoplastic transformation, there is an added influence of the importance of epigenetic alterations. Epigenicity means the molecular changes of the DNA that do not arise from alterations of the DNA proper. So these epigenetic factors may regulate expression of hundreds of oncogenes, such as CDH, KRAS, APC, BRCA1, all involved independent of DNA alterations and all involved with cell motility and cell invasion. And for example, the inactivation of the mismatch MMR genes by promoter methylation is not related to any inherited factor. So the liver epigenome is extremely sensitive to highly variable environment because, as I said before, the chronic inflammation, fibrosis, and mutation stage are prone to environmental influences to these epigenetic alterations. And these epigenetic alterations will occur through lifetime exposures, through DNA interaction, and in cancer evolution phases. The lifetime exposures, as I said before, will include hepatitis B virus infection, which is endemic in Africa, acquiring it during pregnancy and in utero, childhood aging, the Asian ethnicity, which may account for the endemicity in that area, metabolic risk factors, normal body weight, nutrition, physical activity, microbiome, toxins, aflatoxins. They're all lifetime exposure epigenetic factors. And of course, the DNA interaction will involve mutated epigenetic regulators of these genes, these oncogenes, the epigenetic alterations of DNA repair mechanisms through DNA methylation or hypomethylation, the modifications of host histones, and higher order chromatin regulations. So the epigenetic modification commonly occurs in the CPG annotations of the genome. These are the areas which are prone to hypermethylation and hypomethylation within the genes. And you could see that the CDKN2A tumor suppressor gene is frequently silenced by DNA hypermethylation. And hypomethylation will give rise to chromosomal and genome instability. So aberrant DNA methylation and copy number associated is associated with significant poor survival. Again, the microRNAs are very important in cancer, as the elevation of oncogenic microRNAs is indirectly linked with DNA methylation, and it causes silencing of the tumor suppressor genes. So downregulation of the tumor suppressor mRNA will reduce the inhibition of the oncogenes, as seen here. And tumor suppressor mRNA-128 modulates the effects of TP53 through MD-M2 expression, reduce M1R122 expression in IDH2 mutant HCCs associated with a poor survival. So the molecular consequences from DNA methylation will involve increased tumor growth, invasion, metastasis, and increase the field susceptibility to malignant change. And it will cause tumor promotion, inflammation, growth, deregulated metabolism, which will give rise to growth, invasion, angiogenesis, and metastasis. It will avoid immune destruction, invasion of the immune cells, and will cause evasion of apoptosis. So the therapeutic implications are that the circulating tumor DNA methylation could act as an accurate test for detecting HCC and AIDS treatment stratification. Although there are few clinical trials of agents targeting epigenetic alterations for HCC, DNA methylation inhibitors such as acitidine, which incorporates into DNA, may also prevent methylation in myeloplastic disorders, and it may sensitize HCC cells to sorafenib, the non-tyrosine kinase inhibitor. And the concomitant use of HDSC inhibitors along with sorafenib gives promising results in small trials. A positive family history as well is associated with an early appearance and aggressiveness of HCC, but a first-degree family history of HCC is a good prognostic factor for improved survival in patients with HCC. because of the early resectable aspect of the tumors, and probably because of the lack of underlying cirrhosis in most of these patients. So in conclusion, I would like to say that a great attention should be given to the role of primary genetic and epigenetic factors and their interactions in the manifestations of HCC. There are several levels of epigenetic disruption involved in carcinogenesis and a stepwise progression towards metastasis or incurable disease. Monozygotic twins are suitable models for elucidating these disturbances of the hepatic epigenome, and the susceptible loci to the environmental factors could be found. The advancements of next generation DNA sequencing will increase the understanding of the genetic and molecular pathology of liver cancer, and studies will lead to robust epigenetic markers for detection, risk assessment, and improved drug targeting and delivery of pre-existing treatment modalities. The mechanisms of epigenetic control may offer an alternative path to even acquiring stable oncogenic traits. So, and of course, prevention is better than cure. Since the greatest epigenetic factor is hepatitis B, a proper neonatal hepatitis B immunization scheme with optimal timing, which means giving immediately or within 12 hours of birth, with hepatitis B immunoglobulin at the contralateral site, will reduce the incidence of HCC in the endemic areas of the world. Thank you very much. And this is where I come from, Boya, with Mount Cameroon, the volcanic mountain, the second highest mountain in Africa, taking its origin from the Atlantic Ocean. Thank you very much.
Thank you. Thank you, Elroy, for this interesting presentation. So now we have an overview of the disturbances of hepatic epigenome in familial hepatocellular carcinoma. So we are open for discussion. Is there any question? So you mentioned that the polymorphisms are related to the monozygotic twin in the hepatocellular carcinoma. Are there already identified polymorphisms, or there is just an assumption?
No, it's just that I've discovered from the literature, and but much work has to be done on that.
Okay.
Yes.
Okay, so
it's still a very early type of studies being done on HCC with regard to the epigenetic factors, and so I still